practice. Okay.
All right, great. So welcome to our introductory meeting of the Suicide Care Research Center Pilot Grant Program. We wanted to give you all some information about our RFA and the process and who we are and what we're trying to achieve. And so I'm going to kick it off. I'm Kate Contois. I'm the director of the overall Suicide Care Research Center. I'm then going to kind of hand it off to my colleagues, Doyen Darnell and John Fortney, who lead up the team science core of our center through which our small grant program runs. And Molly Adrian, our methods core director. And you've been hearing from Julianne Salisbury, who is our SCRC manager and also heads up the policy core with me within the center. So our goal is that you, by the end of this, should be able to describe what our pilot grant program is going to be like for 2024 and the process and timeline that we're going to be following. So who are we? So we are the Suicide Care Research Center. We are a NIMH funded center. So we received, it's called a P50 center. There were about 6 or 7 of us funded over about a 3-year period by NIMH to work. It's considered a practice-based research center. In other words, they're really looking for research right on the practice line. So working within healthcare, right up against where the services need to happen, as opposed to developing biologics or kind of other kinds of further upstream kinds of things. They're looking for research that's sort of almost immediately deployable that can happen in the real world right away. So our goal in terms of what piece of this have we taken is to improve suicide care for adolescents and young adult patients. So that's 13 to 30-year-olds, their families and their clinicians in outpatient medical settings. So in many cases, this is primary care settings, but it might also be a diabetes clinic. It could be a medication assisted care clinic. It could be neurology. But what we're thinking about is the outpatient medical settings, where a lot of times what we know from the research is that suicidal patients are often identified there and yet do not end up in specialty care and receive the services that they would get in specialty care. Our view or our model is that we want suicide care that can be easily used in diverse primary care and other outpatient medical settings. So we want to kind of develop all along kind of a pathway. So we want to improve how we identify risk. We want to improve how we come up with our risk assessment and kind of evaluate what kind of care needs to happen. How do we do safety planning? How do we develop treatment? How do we follow people in the long term? Kind of thinking all the way along that pathway. How can we make improvements at different points in the pathway that then we can share out to the clinical world? We're focused in the outpatient medical settings like primary care because what we're seeing is that these settings frequently don't know how to manage suicidality within the clinic. They often make referrals that to the emergency room that aren't necessary, that are really overwhelming to the emergency department. The emergency room experience is pretty overwhelming for suicidal patients and their families. Sometimes really aversive things can happen. And this whole exercise of going to the emergency room is pointless if the emergency room doesn't have something to offer, right? So sometimes there's the ability to admit, there's the ability to do other things, but often what ends up happening is they send the patient home, which by default is referral right back to the clinic that referred them out. So our goal is to think about how can we improve what's happening in suicide care, and we're seeing improvements through collaborative care and other integrated behavioral health models, which are getting out there and bringing behavioral health to outpatient medical settings. But the suicide care piece is becoming a bigger and bigger issue, but it's lagging behind in terms of how services have been provided and how they're being built. So our model is transdisciplinary. So what we're trying to do is develop new frameworks, new concepts, new methodologies by bringing together people from really different disciplines, right? So we're including folks from clinical and health services research that might be psychologists, psychiatrists, primary care physicians, social workers, other folks working within the clinical health environment. We have a team coming from biomedical informatics and other sort of technology areas. We have suicide prevention expert folks, and we're looking for folks from lots of other disciplines, from different areas of technology, from business, people who can address legal issues, any kind of discipline that we can bring together with suicide care to develop something really innovative and really different. So the way this works within our larger center is we have already funded several research projects. So we've funded our one R01 and three R34s from the original grant funding. Last year we funded our first two R03s. There will be 8 overall, 2 each year. And we have a methods core that has all the sort of design and sort of research support for the research projects, but is also working on developing its own scientific inquiry. What can we look at if we combine all of these research projects to answer larger questions? We have our policy core. This is one thing that's kind of innovative about our center is we incorporate in a really active way involvement from the users. And so the users down the road are the clinics and primary care health networks, for instance, who we would want to uptake the things that we're doing, but also at the policy and financing level. Who sets policy for suicide prevention? Who funds suicide prevention? And we want our researchers to kind of be aware of what's trending, right? So the new strategy for suicide prevention just came out. It was aligned with a strategic plan of about 200 policy mandates from all different parts of the government. The CDC has mandates, NIH has mandates, SAMHSA has mandates, VA has mandates. They're all, and this is going to set the environment in which what and how are things going to get funded. And so we really want all of our researchers to be really well informed about kind of where things are going. We also want to contextualize our research with folks who have lived experience of suicidality. And in our case, because we're looking at active suicide care, that's mostly focused on people who've been suicidal themselves or have made a suicide attempt in the past and can advise us on the services that they needed and wanted, but also family of people, especially adolescents and young adults who were suicidal and they were helping their families to negotiate, that they were helping their loved one to negotiate the system. So we really want all of our research. We have regular opportunities for folks to work with and get input from people with lived experience, as well as policy folks and folks working in these larger networks. And our hope is by doing that, by the time our research is done, it has much more applicability in the world. And lastly, I'm going to hand it over to Doyen to talk about our Team Science Core, and particularly our R03 program, through which we are focusing on our training and mentoring. And do you want me to give you the screen share back, or do you want me to keep going?
You can keep moving the slides. I'll just tell you when to
Yep.
move on. Great. Thank you, Kate. John Fortney and I co-direct the Team Science Core of our center, which leads the pilot grants program. And our program funds pilot research that will lead to future transdisciplinary suicide care research grants and pilot work that aligns with our mission. Next slide. We plan to fund 2 grants this cycle that will start in January of 2025. Grantees are awarded $100,000 over a 2-year period, and the projects must be aligned with the suicide care pathway and center methodology that Molly's going to describe more in a little bit. As part of the center's aim to promote the transdisciplinary research, like Kate said, we are looking for teams that are going to be multiple PI teams, multiple principal investigator projects with people from different disciplines. And our thought about discipline is that you could define it as either working in a different academic department from someone, or you have different training backgrounds. So, somebody maybe from pediatrics is partnering up with somebody from informatics. One investigator must have previous suicide research experience as evidenced by publications, grants, or a thesis or dissertation. And we do welcome investigators across all career levels and investigators outside the University of Washington. International investigators are going to need to seek approval through our pre-letter of intent consultation process, which we'll describe in a moment. Next slide. In addition to the funds for grants and the funds to disseminate research findings that we offer our teams, our program provides support in implementing our projects and in pursuing future grant funding. So our grantees attend a monthly seminar that helps with project implementation and the conduct of team science for these multidisciplinary teams. We offer numerous center-wide didactics. We have our pilot projects that present their work at our center's monthly all-hands seminar to get feedback from folks across the center. Our grantees can get one-to-one methods consultation, and they get tailored feedback and support for a future grant through a grant writers workshop. And we also have a really unique opportunity for grantees to learn from our non-academic mentors through triannual 90-minute workshops with persons with lived experience, policymakers, and outpatient medical providers. Next slide. We also will invite all of our pilot grantees to join our Collaborating Scholars program. Now, this program is actually currently in development, and we should have all the information about it available for folks who are submitting a full application by the time that people are submitting. But the gist is that we want to offer people additional mentorship in suicide care research. So our scholars will get additional mentorship, and there's additional funds available for training or education in areas that would help advance our scholars' suicide care research trajectory. Next slide. Our current pilot grantees offered some insights into the benefits of working with SCRC. So I'm just going to share these with you. Being able to have access to experts in the different methods and analyses we're using is so helpful. Ongoing guidance and feedback that has been helpful in hiring a research assistant, identifying weaknesses in our initial research plan and how to address them, as well as helped us plan for navigating challenging recruitment areas. I have particularly enjoyed having a chance to network with others in the field and learn from each other. It is not only inspiring and motivating, but very practical in that we share lessons learned and new ideas. Monthly check-ins help keep us accountable and on track. Hearing about other projects and things folks are working on has helped us gain insight into existing and ongoing work that can inform our projects as well. Some reasons to join us at SCRC. Next slide. We have a 2-step application process. This is really designed to help people develop competitive applications. You can access all these instructions at the REDCap survey link that's posted on this slide, and there will be a QR code at the end of the presentation you can use as well. Interested applicants will need to submit a detailed letter of intent by September 15th 2024. Interested applicants can also receive optional consultation from Kate or Molly on the development of this detailed letter of intent. And the link to sign up for this is in the RFA. And that sign up link goes live today and is available until August 15th. Our international investigators will need to sign up for one of those consultations to talk about their project and seek prior approval. We will review our letters of intent and then invite up to 8 applicants to submit a full application. Investigators who are submitting a full application will be required to consult with our methods core faculty. And so this is to ensure alignment with the center, suicide care pathway, and methodology. The next slide will provide an overview of the steps and a timeline for the application. Okay. Working backwards from the big star, we will let applicants know about whether or not they are funded on December 20th, again with a start date for January 2nd, 2025. Those invited to submit a full application will need to submit this by November 10th. Required one-to-one consultation for full applications will occur between October 7th and October 18th. And then there's optional methods core office hours between October 21st and November 1st. So you can get even more support on the application if you would like. Potential applicants who submitted a letter of intent will be notified whether or not they are invited to submit a full application on September 15th. Actually, I think that's when I think I have the date in my note wrong about due September 15th. So we will get back to people, I think, by the 5th of October. Optional one-to-one consultation on letters of intent, again, is available June 26th to August 15th. And then we just really want to ask people, really encourage folks who are applying or thinking about applying or submitting a letter, please watch our videos. We have a number of great videos that are pre-recorded that cover the center's suicide care pathway and our methodology. And there's links to these videos available in the RFA. And that will be super helpful in the process. And we'd really like to have people do that, especially if they're going to get consultation from Molly or Kate. All right, so I'll turn it over to Molly.
Sounds good. Thanks, Joanne. So as Kate and Joanne mentioned, the focus of our Suicide Care Research Center activities are on the suicide care pathway. And so this figure just depicts our conceptual model, thinking about suicide prevention activities on this top row, and also highlighting that we think this care is influenced by the acceptability and usability of the intervention, as well as therapeutic processes like alliance and self-efficacy. And so those are really our targets for implementation and clinical mechanisms in blue. And then our long-term outcomes of having these interventions that have been developed and effective and usable, that they have reach and they, get to the people who need them, and that they work really well so that we have reduced suicide risk when deployed. So as Joanne was highlighting, it's really important that applications align and directly map onto the suicide care pathway in outpatient medical settings. So we wanted to be really clear about that as we're seeking to support these projects that explicitly intend to improve care for adolescents and young adults aged 13 to 30. The Methods Core will help support RO3s by providing design expertise and technical infrastructure to answer your research questions. Next slide, please. So we have adopted 2 frameworks to promote and align the work in the center. The first overarching framework is called the Multi-Phase Optimization Strategy, or MOST. And this is the engineering inspired framework that helps us to optimize and evaluate multi-component behavioral interventions with the idea that we need to attend to not only efficacy, but inevitable resource constraints in the setting in which they're deploying. So the MOST framework has 3 phases that are depicted in the purple, orange, and green colors. The first phase is the preparation phase. The second phase is optimization. And then the third phase is traditional evaluation of the optimized intervention versus some other comparator. Most of the projects will be in the preparation phase for our center. We have one project that's in the optimization phase. And preparation activities in the center are really guided by human-centered design and this explicit model of discover, design, build, test, or DBT. In the preparation phase, candidate components could be identified, and there can be, well, I'll talk about some examples from our current RO3s and other ideas for good preparation phase work that would align with the center goals. But we're really seeking to clarify what we think would be effective components to optimize. In the optimization phase, we include an evaluation of each of the intervention components separately, and then evaluation is determining if that fully optimized intervention works. Let's see, I think we could go to the next slide. I'll talk a second more about MOST and then talk about DDBT, which is really the other framework that will be incorporated in RO3 work. So this slide here is really just thinking about the components, these multi-component interventions that we're developing along the suicide care pathway can be defined as really any part of the intervention that can be separated out for study. So this, we can think about this as the features of the intervention content. So that can be like the cognitive restructuring, different modules for evaluation, different skills or medications. It can also be the features of how a program is delivered. So whether it's an in-person or telehealth, what number of sessions, any sort of features of how the program is delivered. It can also be features to improve compliance. So are there ways in which people can get reminders or alerts, or is there opportunity to use gamification to help enhance compliance? And then finally, features to improve the fidelity. So just making sure the intervention is intended, is delivered as intended. So this can be things like training or technical assistance, having chat features to help support adherence to the intervention component. So preparation activities really focus on identifying, refining, or piloting these candidate components in any of the dimensions noted here. Next slide, please. Okay, so I've mentioned the DDBT framework, which is our human-centered design framework that we've adopted. And we are really aiming to, as Kate was describing, have co-design teams that partner together to have really pragmatic work that is closely aligned with the clinics. So we are using input from people with lived experience, for providers in real world settings to try to have the most acceptable and usable interventions developed as possible. So the DDBT framework is an iterative sort of problem-solving methods to ensure that these interventions are usable and designed in partnership with those who use them. So all research projects in the center are asked to align with the DDBT process. And the very sort of first step or phase of DDBT is discover, where you'll B, identifying the needs and perspectives of end users. So end users is anyone who's interacting with the intervention, and understands the context of use in terms of its barriers, constraints, and facilitators of the intervention that you're proposing. If this discovery work has already been done, you can identify those needs and perspectives, and you understand the context of use. If you establish that, then you can move on to the design phase. Design phase is really where you're synthesizing those design requirements that were identified in the discover phase against user needs, and ideating all of the design concepts that would solve for those user needs. This design process is iterative with building process. So the build phase is where you're developing low fidelity prototypes and testing them with feedback to refine a solution. And so you can go between design and build phases. That's why we've got the sort of circular arrows where you can design something, get some feedback, go back and design, redesign to help ensure it's meeting the end user's needs. So it's really meant to be sort of flexible and interactive phases. Once you've done that work and you have, you're satisfied with your prototype, you can move along to the test phase where you develop and pilot your high fidelity prototype. Okay, next slide. So for the RFA, we're really interested in projects that focus on the scalable intervention or service delivery strategies along the suicide care pathway. So those two aspects are required to be responsive to the RFA. Next slide. And some activities that would be reasonable for the RO3 and preparation phase goals include conducting needs assessments for end users for a novel intervention, identifying a conceptual model and their candidate components, operationalizing the optimization objective, or really how you'll evaluate optimization in the next phase based on the settings, needs, and constraints, and conducting a usability evaluation of intervention components, or even pilot testing intervention components. So lots of great activities that fit within this preparation phase work that would be highly responsive to the RFA. Next slide, please. So as Kate was noting, we have already 2 RO3 projects that were funded last year. So we thought it could be helpful to just highlight what those projects are focused on to give people an idea about the scope of the previously funded and responsive projects. So the first RO3 that was funded is called the HOPES project, and this is led by Denise Chang. And this project seeks to understand the needs of adolescents and young adults and their caregivers with respect to caring contacts and remote suicide risk monitoring and primary care, and then use that information to develop an initial protocol for those interventions. You can see the figure here is their preliminary conceptual model that highlights on the left the intervention components that they're evaluating. So this is caring contacts, the risk monitoring tools, and educational content. And they have identified their target mediators around belonging and support, the timing of clinical support and management, and improving self-efficacy, as well as more distal outcomes around engagement, satisfaction, and reduced suicide risk. So you can see here that this application is highly responsive. It's got intervention components. It's focused on outpatient medical settings, and is in the age group that we are interested in. Next slide, please. The second RO3 that was funded is called Wise Path, and this was led by Sarah Danzo and Laura Richardson. And the aims of this project are to identify design requirements and prototype some components of an app that is seeking to support adolescents and young adults at risk for suicide to be deployed in the outpatient medical setting. So the initial conceptual model outlines some of the functionality to be evaluated. So it's got this components of the intervention of having a dyadic paired application where both the caregiver and the AYA are connected in that communication. It also has a component of routine safety checks, skills instruction, and a crisis survival kit. And these components are suggested to improve caregiver communication and self-efficacy and increase engagement with outpatient services to eventually reduce suicide risk. So we wanted to just highlight these two examples to give people an idea about what the prior successful applications have looked like and how they have communicated that with their conceptual model. Next slide, please. Okay, so in addition to the requirements of aligning with the suicide care pathway in each group and our frameworks, we are also, the methods core is responsible for integrating data across projects to result in greater learnings about the center as a whole. And so we ask that research projects use specific measures when they are engaging in this work. So for RO3 projects that are used in DDB, Discover, Design, Build phase, we'll be asking to use measures around acceptability, feasibility, and usability as some required measures. So we've got really great overview in the asynchronous recordings seminar series that Doyen was noting that really outline each of these measures and the goals for their use, which we highly recommend that you watch as you're developing your RO3. I think it'll be really helpful. Next slide, please. And then as people move into test phase, which you know is probably outside of the scope of RO3, but just to orient to future work that may happen, we also have required measures. If you're collecting these constructs, we ask that you also use the measure that the center is using so we can integrate that data across projects. So when people are doing their real world pilots or in their test phase work, and they're asking participants about suicidal ideation and behavior, we ask that you use the Haas and the Columbia just so we can integrate all of the data collected as part of the center. So that was a pretty brief overview of the methods that we're using center-wide. And I think that we're like right on time for having an opportunity for participants to ask questions and get some clarification about things that we didn't have a chance to cover or didn't cover clearly. So with that, I think I'll hand it back to our Grand MC, Dr. Comtois.
Thank you, muted.
Thank you. So we wanted to loop back to you all to see if you have questions about any of the elements of this or about applying in general. And we don't have any particular direction for it. We're kind of want to open the floor to you all.
I also, if I just realized now, Kate, that I missed my last slide, so I can present them if people don't have any comments. It's really just about how the Methods Core will collaborate with you. Joyanne had covered it, but I can also talk about it if people are interested.
I can pull that back up here. Hold on.
Oh, sorry.
No problem.
So just to be clear about how Methods Core will be involved, we're really excited to support the RO3 projects. And as Doyen had outlined, we are really happy to give feedback on the LOI and make sure it's aligned with the goals of the center. And then we have those required consultations at the proposal phase. And then if your project is awarded, then we have an intake process, and we help to identify ways to have a really rigorous project that's consistent with the center and meet during phase transitions. Like if you're doing a discover phase and then a design build phase, after you've done your discovery work, we'll meet to talk with you about your learnings, collect some data about your process, and then help prepare for your next phase through REDCap builds and other supports that you may need from the Methods Core. We have a seminar series. Some of those are asynchronous and recorded, which you can watch prior to your application being submitted. And then provide some technical assistance through REDCap data builds and translation into other languages. We're working on Spanish, Chinese, and Vietnamese, and hopefully support you through your grant lifecycle.
And we can I'll leave this up here while we kind of take questions. Oh, am I still on mute? No, I'm not still on mute, but oh my gosh, this new Zoom is totally confusing me. Oh my gosh. Okay, hold on. I can do this. Okay, so then I lost, I didn't even hit a PowerPoint button and it took me out of, okay. I don't even know what happened, but I'm going to stop now. So we can also offer interpretive services if you, so all of our questionnaires and work within REDCap will be translated into Spanish, Chinese, and Vietnamese as appropriate, but you may also be conducting interviews, in which case you might need some support around interpretive services. So we can provide that as well. So now let's try asking for questions again.
Kate, for clarification, it's a 2-year grant, potentially with a no-cost extension if that was an option. So part of our design was a little bit exploratory to learn more about the state of a fit. So we're part of a practice-based research network, which is an umbrella to many rural and potentially American Indian or Hispanic serving clinics across rural Washington. And we really hope to get a sense of kind of the pulse in rural communities and find those champions in that first year by doing a mass survey to the clinics that we partner with. But I'm worried in 2 years how we would implement an intervention so we could look at finding our champion clinics or clinics that identify the most concern or agreement to participate, but then we would have to implement an intervention within the following year. Are you finding, so these would have to be, I'm just concerned that we would be effective in our intervention implementation. The expectation is we would complete an intervention.
No, not necessarily. And feel free to sort of add to this. Wait a minute. I wanted, so the larger center is kind of imagining this whole thing, but we don't imagine that an RO3 is going across this. We don't even have a single study in the evaluation phase.
Okay,
All
okay,
of our stuff's at the front end too, but this is sort of the larger picture.
okay.
So what we would expect is that you would be in the DDB,
Okay.
and then how far you are between the DB, you know, the build and to the test really depends also in part on where you start. So
Okay,
as Molly was saying, some people actually know a fair amount based on the other work they've done about the environment that they're in, the problem that they're uncovering. So the discovery work is already done, in which case we would expect they would pick it up somewhere in design and
mhm,
build and might make it to test. But if you're all the way over at the discovery end, it's unlikely that you could get in 2 years with this kind of funding
got
all
it.
the way through a high fidelity model that you could test, unless it was something like a very simple web-based, I'm not even sure if I'm convincing myself of this, but like in theory, if you had something that was very simple and technical that could be, you
Mhm,
could run people through the protocol in very short periods of time, you might be able to do a little bit of test work, but we
mhm,
would not expect, unless you have something already into build,
got it.
right? That you would, so is that fair, Molly and Doyen? Do you think I'm capturing that well?
Yes.
But I think reviewers might not like the fact that you hadn't identified partners yet for the application.
Mhm,
That might be too in
Uh-huh.
preparation for doing the DDBT framework.
got it. Yes, we could bring partners in potentially, or a series of partners, and then have the expectation that we would hone in on a subset of a broader based on urgency, or, if we could end up with 3 or 4 targeted partners to develop intervention.
I'll say most applications have come in with an identified partner. They might
Okay.
not know who within the organization exactly they're going to be
Okay,
conducting research with, but we don't see very many applications where we're like, there's a practice-based research network and we're going to identify some of the clinics to participate with.
okay,
It's not that it, we wouldn't exclude you for that reason, but reviewers might find weakness in that.
okay.
To provide.
Go
letters-
ahead, Maria.
Oh, I was going to say, so provide getting letters of intent or interest from the clinics.
Yes, that would
Would
be, that would strengthen your application no end.
Okay.
Or even having them as partners in the,
Mhm.
as investigators.
Mm-hmm. Okay. Yeah, because I think, where we're going to be, definitely it's going to be, DD and then right at the end B, recommendations, basically. We've got, some ideas, but certainly need to go back into these particular communities.
Yeah, I mean, you've got time to build those relationships before you put the application in.
Mm-hmm.
Mhm. Okay.
I think
There's
that,
there's a question in the chat that
yeah,
you should probably answer. Yeah, I imagine your partnership building activities would continue through the application of the full application itself. So I would think getting an approved LOI, I think the turnaround, Doyen, is how long? Like 6 weeks, maybe?
1 month. A little over a month, maybe.
Yeah. I would work earlier if possible on shoring up your partnerships.
Mm-hmm.
and I think the partnership is sort of needs to be at the level it needs to be. Like one thing I've learned is sort of asking people to partner, like, yes, we promise that once this thing is created, we'll do it, is a level of promise that that might be more than someone's willing to commit to. But if you kind of explain the DDBT model and the idea of we're really in this DDB phase, and I think that people can speak to their willingness to engage in that without making promises that they'll necessarily roll out an intervention down the road. I think that those are two levels of commitment, and we wouldn't necessarily expect that an agency is promising to do the intervention. They're promising to work with you to co-design the intervention.
Mm.
Yeah, and if you have an existing relationship with a partner, that's fabulous. That certainly strengthens your application. This is also the reason that Molly and I wanted to provide consultation between now and when the LOIs are due, is there may need to be, in some cases, some matchmaking. So we talked about before the MPI model, and you might need some help in finding someone from another discipline, or from, if you're not in suicide care research, you might need help finding somebody in suicide care research, and Molly and I can help with that. I tend to do more stuff on the adult side, and Molly tends to do most of her stuff on the teen side. So we'll kind of sort out depending on the projects. But you might also need some help in trying to connect with a clinic where there might be folks who would be interested. And so one of the other kind of parts of my life is trying to build up relationships with clinics as a center, so that we have clinics who we could over time approach. And we have some clinics who've expressed interest now, and I'm sort of steadily working on trying to build that, so we can potentially offer some help in trying to matchmake people with clinics if that's not something that you have. Not making any promises, of course, because I'm not speaking for a clinic. Other questions? They do not have to be located in the state of Washington.
Okay.
Yeah, we have a tendency toward the kind of Pacific Northwest kind of whammy region, but we don't have any explicit limitations around that. That tends to be like, for instance, if you were asking for someone to help matchmake you with a clinic, that's the region in which I've been doing most of the clinic development. But there's no rules in what we're doing.
Okay.
And in terms of having all these different, I guess, cores, if you have methods core and so the level of support, I understand, that they're there to advise us during this sort of preparation process, but once the grant, let's say it's approved, the project is approved, can we still rely on them for some level of support, or?
Could be more than you wanted.
Yeah.
Yeah.
Yes, I would say you could feel confident in that. Yes.
Okay.
So as Doyen mentioned, we have monthly meetings of everybody who has an R03 grant. So we can sort of, all the R03 folks and the collaborating scholars together we can keep an eye on things, as well as we have qual and quant experts and human-centered design experts who can advise on how to do the DDBT model, or how to design a study within the most framework, in terms of like thinking about oops, I'm going the wrong way. The different components, and how do I think about the components, and how do we build the conceptual model. We can do some advising of that ahead of the LOI to kind of help you get into alignment, but this kind of consultation tends to continue right along.
Great. Thank you.
And if
So
we're in the discovery phase, or we partner with specific clinics in rural Washington, and working with providers trying to gauge, we're really curious about the changing climate coming out of COVID and the volatility in some of our rural communities on certain topics. But just the level of engaging with minors towards implementation. So we could kind of toggle between that discovery, design, and build within this grant and see if the clinics could potentially test run implementation.
yeah, I think for the purpose of writing the grant, I think, you know, we have had, you know, some applications that were sort of, we felt like they could be doing more with 2 years worth of time. I wouldn't totally like, you know, undershoot. On the other hand, we're not, like I said, expecting that people, it's not, it's, you know, I'd rather see sort of, at least speaking for myself, I would rather see something that really is got enough traction to do a good job at the phases that they're at than to have somebody feel that they need to get all the way across the DDBT, and then that means they're not doing as good a quality job at the earlier steps in the process. So I think it's, I don't want to give the impression that people need to have everything at test in order to have a competitive proposal. I don't know, Doyen or John, if you have anything to add to that.
Absolutely agree. Yeah. I think it's so much about where the state of the science is at in the readiness to build something in that in the context you're wanting to work in. So what research needs to be done before you're ready to do the design? And then maybe it's ready. The research has been done to do the design, and now that's the part you want to take on. One thing to keep in mind is that an important part of a competitive application is the trajectory of grants that would come after this. So, you know, theoretically, an R3 level grant, what we're doing, you would hope to see somebody apply for an R34, you know, getting a lot more pilot money. Basically, it's still pilot work, but much bigger scale pilot work where you might actually be testing something, piloting a test of something, or an R21 where you're really still working on some of the innovations you're trying to do.
Yeah, I think that's a good point, that we're in an interesting place where we're really trying to straddle both making actual change in the world, having things that are very practice-based that will actually be developed and used in the world and not be another research intervention that sits on the sort of virtual shelf of the researcher. And at the same time, we are part of the National Institute of Mental Health's pipeline. So we're really looking for people who want to go forward, applying for further grant funding, and kind of having the idea that whatever they're developing is going to move on up through the grant, through other grant mechanisms, although, you know, could diversify to PCORI or to you know, the VA or the DoD or any number of funders. I'm not so much particular about the funding, but just the idea that this is research that's going to progress, because that's the point of sort of conveying this initial model, that's the model of the whole center, is we want stuff to actually get optimized and actually get used. And that means people need to continue their research and have a research trajectory. So
Great, thanks everybody for coming.
I was gonna say it's right at 4 o'clock. And I'm gonna go back by clicking a zillion times. I'm gonna get back to our QR code. And I also saw that Doyen, you dropped the link in the chat.
Yeah.
So we hope that you'll follow up. Like I said, we're available, Molly and I, for any kind of coaching and consultation over the rest of the summer, and we hope to see applications in the fall.
Wonderful.